We'll call this meeting to order Wednesday, May 11th. Steve, do we have to do a roll call or do you already have that?
I should do a roll call just to make sure I have everybody.
All right. Can you do a roll call and then at the same time, folks, if you could just introduce yourself. So Steve, we'll kill two birds with one stone.
Oh, as far as, yeah. Okay. So Will Hiller,
Present, AMR operations.
Tina Nieto,
Present, Monterey County Law Chiefs.
Sam Klemick,
President, Monterey County Fire Chiefs.
Jim Langborg. Okay. Harry Robbins,
Here, Harry Robbins, Citizens Rep Peninsula.
Jody Schaefer, Luz Garcia, Paul Wood,
Here, Monterey County City Managers. I'm gonna go look for Jim Langborg.
Nick Greenson,
Here, Physician Representative.
Greta Steinbrunner, Carla Spencer,
Good morning, Carla Spencer from Hospital Administration.
thank you. Alternates, Mike Esslinger,
Everybody, Mike Esslinger with the American Medical Response.
Roger Reinhardt, Cheryl Getz, Ben Harvey,
Oh, I did. Yeah, they didn't want
no,
that as a panelist, so. I
Noah,
didn't know if you can, and I'll update you.
Noah Hawthorne, Joe Cafaro,
Cafaro Hospital Council.
Keith Boyd. Ex officio members, Teresa Rios.
Keith Boyd, Law Chiefs Alternate, King City PD.
Ah, wonderful, thank you. Teresa Rios,
Teresa Rios, EMS Agency.
Gary Millay, and Leanne Vygotsky has said she would not be here today. Any guests who would like to announce their presence?
Steve, this is John Anthony, Monterey County Parks. I didn't hear my name.
I'm sorry, I guess I missed you. Sorry, yes, thank you. Any guests would like to introduce themselves?
Hi, good morning, everybody. Sorry, Alex Asta, AMR Santa Cruz.
Michelle Kalinsky, Tom.
John Burley, EMS Medical Director.
Morning, Jeff Horner, CalStar.
Justin Reyes, Monterey County Regional Fire.
Sandra Flores, AMR.
Jim Lamborg, I see you're here.
Sorry about that. Jim Langborg, representing County Chiefs BLS Fire.
Rachel Nealand, AMR.
And EMS agency staff, Steve Brooks, EMS agency.
Kimberly Hernandez, EMS Agency.
Deborah Hopgood, EMS Agency.
Is anybody else who would like to announce their presence? Thank you very much.
Thank you, Steve. Now we're open for public comment. Anybody who has a public comment not to exceed 3 minutes. Steve, I've not seen any hands or anything, so we'll move on to approval of the past EMC meeting minutes. I hope everybody's had an opportunity to look at them. There's actually 3, March 9th, April 8th, and May 4th. And if I could get a motion to approve those.
I have a motion to approve all 3 as a unit.
Can I get a second?
Second.
I'm sorry, I missed the second.
Klemick.
Simon Klemick, thank you.
All right, Steve, if we could get a roll call.
Roll call, Will Hiller, Tina Nieto,
Aye.
Sam Clemic,
Aye.
Jim Langborg,
Put a thumbs up.
Aye.
thank you. Paul Wood,
Aye.
Dick Greenson,
Aye.
Carla Spencer, John Anthony,
I'll abstain because I was absent for the last meeting.
thank you. Carla Spencer,
Aye.
perfect, thank you. We are good.
Thank you, Steve. Now moving on to reports. I don't see the blue stuff after it. So is that just attachments, Steve? Or is that a
Yes.
verbal report?
That is correct. The Medical Advisory Subcommittee minutes are attached as are the Ops Committee. However, as far as reports go, we do have probably something from Deborah Hopgood for the QI program.
Yes, there is a written report attached to the agenda packet. Just as far as highlights, our CQI tag group met in February, conducted a review of the state's EMS authority core measures and ketamine administration data from quarter one. We are working on some improvements to documentation standards based on the information we obtained from the core measures, and we'll be working with the provider agencies to implement those changes. Also of note, the base hospital physician orientation training was conducted by Dr. Burley, and it's now available on the EMS agency's website for anyone who wishes to refer to that in the future. That's all I have. Happy to answer any questions.
Okay, I don't see any hands or anybody speaking up, so we'll move on to EMS system performance
Oh,
metrics.
Just one more thing. Yes, we didn't put reports because this is a report section, but we do have EMS agency updates from Teresa Rios and then we'll have Moak from.
All right, let me back up. Sorry. So let's move on to EMS agency updates. Teresa, and I apologize.
Thank you, Chief. There is also a staff report included with your agenda packet. Just a couple of highlights from those updates. One is that we released a memo. We received notification from the EMS authority that as of July 1st, EMTs and AEMTs who were approved to administer the COVID-19 vaccine will no longer be able to do that. We presented at the fire chiefs meeting, just, and try to get some feedback and see if there were any red flags, any concerns about that. There didn't seem to be any. The other highlight is that we applied and received a grant to offset the cost of training of staff to administer the COVID-19 vaccine. I want to recognize the effort of Deborah Hopgood, who applied, completed the application, got data from all the stakeholders, and follow up on that application until we got it. The funding is based on population. So for Monterey County, in our population size, we were awarded 20 grant that is being distributed to the agencies that have participated. We want to recognize the agencies that have participated in the administration of the vaccine. It's been a lot of help, a lot of effort on their part to be out in our community, ensuring that our residents are vaccinated. We also presented that piece at the fire chiefs meeting with the proposed methodology for distributing the funds. Everything seemed to go okay, so we will be dispersing those funds after this meeting.
Okay, any questions for Teresa?
I do have a question. It's Justin Reyes from Monterey County Regional Fire. My question is I know that the EMTs and the AEMTs are going to expire July 1st, but will paramedics still be allowed to do testing and vaccinations?
Yes, they will be able to. EMSA put in place that those LEMSAs who had applied for LOSOPs and gone through the MDAC review process, we're able to continue at least currently through the duration of that LOSOP approval. So that'll put us into 2024 for paramedics being able to complete testing and vaccination administration.
Okay, thank you.
All right, any other questions for Teresa or Deborah? All right, see no hands. We'll move on to Mohawk. Deborah?
Sure. And again, there's a written report attached to your agenda packet. Just a quick update on the latest data. As of Monday, the case rate and test positivity has been increasing in the county slightly. So we're up at 10.4 per 100,000 for a case rate and 4.1% for test positivity. Luckily, we haven't been seeing as large of an increase in hospitalizations, with just 11 hospitalized as of yesterday. We're seeing very small incremental increases in vaccination data, about 0.1% per week, pretty consistently. I would put it out there that if you or are a member of an organization or a group in need of testing supplies, we do have those available through the Mohawk resource request process. And please feel free to reach out and request those if you do need them. Otherwise, I will put in a plug for the EMS providers and fire departments in particular, that there have been several after action reviews going on by different organizations throughout the state. And I would encourage you to participate in those if you get the opportunity to. It's a great opportunity to provide some input on your experiences during COVID-19, any lessons that you learned, and then to hopefully help shape some best practices in the future. So that's all that I have. Happy again to answer any questions.
Okay, Deborah, I'm seeing no hands or anybody speaking up, so we'll move on to EMS system performance metrics. Kimberly, communications.
Good morning. The communications testing reports were included in your agenda packet for 800 megahertz radio and ReadyNet. I do want to apologize that there was some discrepancies in February's numbers, so I'm going to share the updated. Unfortunately, we didn't discover the error until the agenda packets had gone out. So let me just share my screen. Just a second.
Kimberly, also after this meeting, can you send the updated information to everybody?
Yes, I was going to advise that I was going to do that. Thank you.
Thank you.
So for February and March, you'll see on the screen, March again was correct. It was February that was incorrect. It was just the numbers were mixed around. I just wanted to point out that you'll see CHOMP's percentage for 800 megahertz was extremely low. That was due to they discovered they had a faulty cord on their 800 megahertz radio that they have since corrected. They got it fixed at the beginning of March, but they did communicate that with us and AMR dispatch. So again, going back to that, we've been communicating with them regularly on the 800 megahertz and the ReadyNet testing. So those lines of communication are more open so that when there's issues or problems, they're able to reach out and everyone's on the same page on what's going on. And then I'm just going to share the ReadyNet. And if anyone has any questions, I'll be happy to answer them.
Kimberly, I'm not seeing any questions.
Okay.
I heard a little noise. Okay, no questions. So moving on to contract compliance.
Okay, so the contract compliance PowerPoint was included again in your agenda packet. I wanted to point out that overall priority 1 increased in February and in March. Priority 1 overall was at 96% compliance and and in March, priority 1 was 95%. So highlighting that, I wanted to go over a couple of things that we felt were important to note. Hold on just 1 second, I'm going to share a PowerPoint. Can you see my screen? Okay, so we wanted to go over factors that impacted response time compliance, not only the negative, but also the positive. So the negative impacts to contract compliance, we all know, we've talked about it several times, is when they took the calls out of priority 1, which reduced the calls in priority one from about 2,000 to 200. So that was towards the end of 2019, and the results started showing in 2020 when compliance started going down. And then it increased the calls in priority two from about 200 to 1,600. Also, negative impact was not submitting calls for exemption. Of course, COVID-19 pandemic, which caused staffing challenges, added time to decontaminate the units, increased APOT time. And in January 2022 was the peak of Omicron. And AMR, we've gone over multiple times, had issues with recruitment and retention, constant loss to other agencies, and lower wages than surrounding counties. So moving on to the positive, which we feel is how the increase came about for priority one in the last few months, was moving the remaining Delta calls back into priority one. So previously we had talked about that when the priority one bucket got so small, the majority of calls in there were echoes, which is a very small amount of calls, and there were a few deltas. So we moved all of the deltas into priority one. So it made the bucket from 200 to over 500 monthly. And then it decreased calls in priority two from 1,600 to about 1,350 a month. The change in response time measure, which now calculates, it starts at the beginning the call is received and to include dispatch shoot time and the response of the ambulance response time. The refinement of the exemption process, increased use of BLS for interfacility transports. Obviously that frees up more ambulances, ALS ambulances to respond to calls in the 911 system. The change in response to unconfirmed medical calls. So ambulances aren't tied up on those unconfirmed medical calls until it's confirmed there is an actual ambulance need. AMR increased their wages to retain staffing. And the overload language that was added in Amendment 11, that there's now a 24-hour notice for out-of-county transports for more than 250 miles round trips. That allows AMR to plan ahead, so they're not having to use a system unit. They can maybe add a unit into the system to take care of those transports that are going to keep them out of the system for a really long time. AMR made some system status plan changes in February, which of course is going to help. They could shift some of their resources to areas that were harder to serve. I know AMR's dispatch management has been monitoring shoot time closely, getting crews in service faster. And another big point is that the dispatchers have been more frequently and appropriately diverting ambulances to higher priority calls. You know, they use MPDS for the priority dispatch system. And so moving those, when there's a call, a priority 3 call happening and a priority 1 call goes down, that a unit is responding to that priority 3 call, they're able to divert them to that higher priority call, and that's happening more frequently and more consistently.
One other thing that we need to talk about when it comes to the improvement in the response time is that after we had the implementation of the call interrogation in 2020, we also had COVID. And so that was another impact. But part of what we need to, and so what we are remembering right now is the more recent data of the lack of meeting the response time in priority 1. So one of the things that we did internally is like, well, let's look at the data. Let's see where we were before we implemented the call interrogation and kind of do a comparison of where we were. This is very busy, I know. We drilled down and we looked at it by zone, by priority, by month. And we're trying to find a way to bring the information to the committee in a way that makes sense. But unfortunately, my brain was fried and I didn't find a better way to do it. But if I can walk you through this, is we are looking at the number of months that AMR met response time compliance for each of those years. So you'll see in 2018, if we just focus on the overall for priority 1, in 2018, they met response time compliance 11 out of the 12 months. In 2019, 9 out of the 12 months. But once we go into 2020, when we had the change in the implementation of the call interrogation, and then also the beginning of COVID, and we also experienced, as a result of COVID, more staffing challenges. The staffing challenges have been ongoing. They didn't start with just COVID. But and the fact that we moved most of the calls that were in priority 1 to priority 2, priority 3, then we turned things upside down. So whereas AMR was better at meeting response to compliance in priority 1 in 2018 and 2019, beginning 2020, things turn upside down. Now they're meeting a response to compliance, again, just focusing on the overall row. In 2020, they met it only 3 months out of the year. In 2021, they adjusted, they adapted to COVID and everything. And so they did better, but still not as good as they had done prior to 2020, when they met response to compliance 7 months out of the year. For priority 2, we see that things didn't change a lot because AMR has been pretty good at meeting response to compliance. So I wanted to talk about what response time compliance was prior to the changes, prior to COVID, because we're remembering only what happened in the most recent time when the response time compliance really tanked. But there are explanations for that. So it is not that response time compliance is just jumping all of a sudden. There are several factors, just as Kimberly pointed out, but it's also bringing us back to where we were prior to the implementation of call interrogation and the beginning of COVID and all of the things that have come from dealing with COVID. So I'm sorry about the busy table, but we were drilling down, really looking month by month, year by year, priority by priority, zone by zone, just to really look at and find and be able to explain to you what you're seeing as a shift in improvement of the response time compliance.
All right, are there any questions for Teresa or?
Looks like Michael Esslinger.
Yeah, and if I could just add to some of Teresa's comments as well, one of the questions that, had been raised with us, that with some of the contract changes, depending on compliance, was there any effort or consideration of AMR of reducing unit hours? And I just wanted to, go on record to everybody that, that is not at all the intent. The effort of hours will continue to be the same. But, our base unit hours, I think it's 2,616 hours a week, which is our goal. And of course, we're always striving, we receive sick calls and still working through some of the COVID issues, but definitely as staffing improves that, we expect to continue providing that, at a minimum, those base level of hours. So I just wanted to kind of go on record to let everybody know that, behind the scenes, there's no intent of utilizing, any other measures of reducing unit hours. That's all I have.
All right, any more comments or questions?
Only that I would like to see that that particular graphic be displayed at future meetings. It's a good summary graphic.
Thank you, Harry.
I do have a question. I was looking in the agenda package. I didn't see the presentation. Was that added later? And if so, can that be sent out to the board?
Yes, we were still working on that one after the packets went out. Sometimes we're not able to send everything in order to meet the requirement for posting the agendas. But yeah, we can definitely send that out.
Thank you. Any other questions or comments? All right, seeing none, we'll move on to the next report.
So on the agenda, we have fire-based providers response time reports. There was not a report included. We've internally started talking about some frequency of the reports. So this report, the call volume is sometimes pretty low monthly. So we're going to have an update in July on how often this report will be reported to EMCC so that we can look at more meaningful data.
Thank you, Kimberly. Any questions or comments for Kimberly? All right, seeing nothing, we'll move on to old business. Steve?
Yes, with old business, first item is EMCC membership. And in your packet, we provided a information about the members whose terms are expiring. And I please accept my apologies. We had intended to send a different memo, but the information is the same, is that Dr. Hawthorne and Dr. Greenson for EMCC have initially thought about not continuing to serve. Dr. Hawthorne has graciously changed his mind and will continue to serve here on as the ED physician reps as the alternate, and Dr. Greenson, who would like to step down, is willing to stay on until MAC brings a nominee to the Board of Supervisors for the regular position. So with that, we also have Carla Spencer, Jim Landborg, Paul Wood, Luz Garcia, and Greta Steinbrunner's position that are open and needing to be continued, which we're working with these members to confirm the representative group's nomination, or that the citizen reps are interested in continuing, and we will be taking those nominations to the Board of Supervisors for being placed on for continued service at the Board of Supervisors. And then we also do this for the alternates, Joe Cafaro, Shell Getz, Ben Harvey, which will also go to the board for continuation at EMCC. So if your agency that you're representing has not provided the nomination information to us, please encourage them to do so we can get this to the board so that we can continue to have a full and robust EMCC committee. And any questions?
So we did, just to follow up on Steve, we did bring the nomination, the names of the members whose term is expiring to Monterey County Fire Chiefs Association, so they can do the nomination. And then Chief Nieto, we're asking you for the law chiefs, the nominations that need to be made from that organization for your position and your alternate. It takes us about 4 weeks to get items on the agenda. For EMCC, for MAC and Ops, I appoint the members. For EMCC, those are appointed by the Board of Supervisors. And for us to get those nominations to the board, it takes us about 4 weeks, 4 to 6 weeks, depending on what's going on. So for us, that's why we start the process in March. We try to get the nominations to the Board of Supervisors at the beginning of June. In that way, they can, as soon as they're appointed, we can work with the members, because there are certain requirements, as you know, that you must complete before you are officially seated on the committee, like your oath of office and some other items. So we really appreciate your helping us to ensure that the positions are appointed by the Board of Supervisors and you are officially seated by the July EMCC, which is the beginning of the term for each of the members.
Teresa, will you shoot out a separate email also as a reminder?
I'm sorry, say that again.
Can you shoot out a separate email as a reminder?
Steve will do that.
We will certainly do that.
Thank you. Paul, you have a question or comment?
Yeah, I just wanted to say that the city managers group, it's on our May 20th agenda to consider either me or a new alternate or representative.
Thank you.
Thank you.
All right, any more questions or comments? Steve, I don't see anything, so we'll move on to election of officers, new business.
Very good. So according to the policies related to our EMS committees, we have to nominate and elect the chair and vice chair prior to the July 1 meeting. And it's for a one-year term to serve as chair and vice chair. And it again starts on July 1.
Harry, you got a comment? Your hand's up?
Yes, I'd like to move, put the names of Jim Langford in for chair for the next period, and Paul Wood, with a caveat that both will be appointed by their respective organizations.
And I like to second that motion.
That was fast.
I call for discussion.
Yeah, Harry, what did I ever do to you? That's all I want to know.
All right, I don't see any hands up, Steve, so can we take a roll call, please?
All right, so on the motion for Jim Landborg to become chair and Paul Wood to become vice chair, effective the January 1, 2022 meeting for a term of 1 year. Will Hiller.
Aye.
Tina Nieto.
What was the year on that? Was that effective
Yeah.
when, Steve? I think you had that.
July 1, 2022. That's
Okay,
that's
yeah,
our next,
okay, got it. Aye.
next meeting. It's not today. You're not out that soon. All right, so Tina Nieto, Sam Klemick,
Aye.
Jim Landborg,
Aye.
thank you. Harry Robbins.
Aye.
Sure, thank you. Paul Wood,
Aye.
Nick Greenson,
Aye.
Carla Spencer,
Aye.
John Anthony.
Aye.
For those members who aren't here, may have shown up, Jody Schaefer, Luis Garcia, Greta Steinbrenner. Motion carries. Thank you.
Thank you, Steve, and congratulations to the chair and the vice chair. Moving on now to changes. Let's see who's got that. Deborah?
Yes, Teresa already covered that during the EMS agency update, so unless there are any questions, the update has been provided.
Seeing none, we'll move on to COVID-19. Deborah again.
Teresa also spoke to this during the EMS agency update, so again, unless there are any questions.
All right, seeing none, we'll move on to item D, ET3 AMR. Yep.
Sorry.
I think that this is mine. I'm not sure if Kim wants to start.
No, you can take it. Go ahead, Mike.
Okay, thank you. Well, thank you, everybody, for your time. AMR basically is seeking your consideration to implement a new program that has been approved by CMS. It's currently specific for Medicare patients, but there's definitely efforts to expand the program to other insurance and other patient populations. ET3, it stands for Emergency Triage and Transport, which basically allows for greater flexibility with care of access and options for low acuity patients, and specifically today in a field setting. There's a few different components of it. We're currently only seeking to implement the virtual health, kind of a telehealth component of the program, but there's options in the future where we could expand to being, having the ability to transport, for example, to like a urgent care. The current program, it allows kind of a virtual access to a physician, so that way they could actually assess patients virtually via, like a telelink, And there's different options where they can, do everything from, write prescriptions to referrals and other things, which, may be back to their own physicians. There is a critical timeline that's associated with it. Unfortunately, it's a 5-year approved program, but the mandate is that we would have to be implemented by July 1st. For, just all transparency, there's definitely some concerns that were raised this morning in the MAC committee. And so we've agreed to a special meeting to kind of go through those. But I have Alex Oste with us from Santa Cruz County. He's a clinical care coordinator and also an innovator there, where we've actually, we did implement the program in Santa Cruz, and he can provide kind of an overview of the program and also talk about, just kind of the successes in the short time frame we've had it implemented. So Alex, I'll turn it over to you.
Hi, good morning, everybody. Thank you for having me. I really appreciate the time given to me to talk about ET3 and the successes that we had here in Santa Cruz County. Let me pull the PowerPoint really quick and let me know if you can see it. Are you able to see my screen?
We're good.
Okay, perfect. So ET3 is a federal government program by the Center of Medicare and Medicaid Services, which is a 5-year payment model that aims to provide greater flexibility for EMS teams to address low acuity complaints from 911 calls. As of right now, here in Santa Cruz County and in Riverside County, we only offer the treatment in place option and not yet the alternate destination model. And as of January 1st, GMR, our parent company, has selected to implement ET3 across 62 markets nationwide, and the Riverside and Santa Cruz are the first 2 ones in California. So why are we doing this? The main reason is to expand the access to care options to our community. For years, we've been telling people in our communities to dial 911 to seek medical care, that we are there for all their needs they might have. But that has escalated in these past few years to the point where we are having staffing issues, but at the same time, the number of calls is just going up and up and up. And not always, as we all know, the acuity level of a 911 call warrants an 911 ambulance or an ED visit for that matter. So what we're trying to do is to meet the patient's medical needs by bringing an ED physician via our iPad or patient's device to the scene of a 911 call in order to improve the operational efficiencies on AMR side, to improve the system of the local hospitals by not bringing patients there and increase ED wait times, and overall increasing the patient experience so that they can be treated in the comfort of their own home. They can get these physicians to prescribe their medications and avoids them a very costly visit to the ER. The guidelines for our ET3 program are very simple for our medics, for them to follow. It's based on not only low acuity complaints, but also on the vital signs. So at first, our medics will get on scene of a 911 call. They would perform a focused history and physical exam. And then they would ask the patient if they have Medicare or an appropriate insurance to be able to offer this new service. And the way we would implement it is by asking them if they still want to go to the ER or if they're comfortable by having talking to a physician over our iPad or their device and have their questions answered in that matter. This is the worksheet that we have. I can share this with you guys at a later moment, but there are disqualifying criteria such as high acuity complaints, vital signs outside of the parameters highlighted here, and complaints that are difficult to examine on scene that require more thorough examination, like lab work, for example. So the treatment in place is provided by a national provider network called Envision Healthcare. They provide 8 to 10 physicians on at all times, 24/7, that are able to respond to our telehealth request. These doctors are all ED certified. They've been working in EMS even before they went to medical school, and they have multiple years of experience in both EMS and the emergency department. The way we document these e-visits is very easy and very simple. At first, our crews are going to do a thorough exam of the patient and gather their history. And then they're going to document on ImageTrend, which is the program that we use here in Santa Cruz, the disposition of the patient. In this case, it will be treated and transfer care to telehealth provider. At that point, our crews can facilitate the exam with the physician, taking further vital signs if needed. But the doctor now is able to talk to the patient and answer their questions. This whole system is very simple to use, very easy, as long as information is inputted correctly, of course. As I was saying, all these physicians are certified in California, so they're able to write prescriptions. We give the patients the choice to select their own pharmacy. And once the telehealth visit is confirmed, then we can just initiate and talking to the physician themselves. On the side here, next to the telehealth call mode, there is a visit details where our paramedics and EMTs are going to write a quick note to the physician just to give them an idea what they're about to see on the patient. At that point, our team is going to give a quick report to the physician as they respond, and they can either give the choice of the physician to connect directly with the patient with their phone number by using their tablet or their phone, so that our AMR crew can focus more on the patient or even getting ready for the next call. As of right now, we have a 100% QA on all ET3 encounters. I follow up with all the crews. I've started recently trying to call the patients as well, but only 2 have responded, considering I call from a different number. Many people don't recognize. One did not even want to talk to me. It's like, no, I don't have time, since telemarketers are kind of ruin the market for us. But we do follow up with all the patients. I personally have access to the Santa Cruz County Health Information Organization. So I'm able to follow up with the patients and see if they still went to the ER, maybe by private vehicle or with other means. And so far, we have had 6 successful ET3 calls since our implementation here on March 18th, where patients had their concerns evaluated by the physician, and we saved the transport to the ER. For right now, until last Friday, the only patients that were eligible for this were Medicare, but I've managed, along with other AMR leaders and EMS leaders in the industry, working with the US Senate and the US Congress, trying to expand this to Medi-Cal and Medicaid. And as of last Friday, the California Central Alliance has approved the use of the telehealth system for the patients here in Santa Cruz County. So that's been a pretty good victory that is going to expand the offering to our community here. So if the patients do not want to participate in the telehealth visit, they still have the options of going to the ED, but we'd like to highlight the lower cost and savings on copays. When it comes to money, AMR only gets reimbursed by Medicare as of right now for the cost of service of showing up to the 911 call, minus the mileage since transport does not occur. And the patient gets only billed, I think it's about $87 per call. So it's very cost effective, saves a lot of money on the patients in terms of an ED visit and time, especially with a low acuity complaint. Who knows how long they're going to be at the ER for, and then the problem of bringing them home to assist again, which might even need a further private ambulance to transport them home if they're bedridden or they meet Medicare requirements to ambulance transportation. So in the previous meeting this morning, we were asked for some nationwide data. And as of right now, I was able to pull some data from Envision Physician Services, which is our provider. As of April 2022, the typical response time is 2.8 minutes. And that means from the moment our crew decides to call the doctor and the doctor to pick up the phone, it's 2.8 minutes. And the typical visit duration is about 10.8 minutes. And that's to add to the on-scene time of the crew to perform the initial exam by themselves. Here in Santa Cruz County, I've averaged the on-scene time from the time that the ambulance arrives on scene to when they clear. And the total time on task has been 28 minutes and 32 seconds. As you can see, the cumulative visits month over month since it's been implemented nationwide have been significantly higher with about an average of 55% of treatment in place options for Medicare patients. So as of right now, we had about 1,000 ET3 calls, and about half of that have been concluded by non-transporting these patients to the ER. So I know there were concerns initially on the data nationwide, and I was actually able to pull it in between these meetings. So this is, I want to say it again, it's a great offering for our communities. In Santa Cruz, it's been relatively successful since we started a month or so ago. All the patients have had positive outcomes for right now, and the fact that we're able to expand it to further payers will help us as a time on task, will help the patients save time and money, and is going to help the EDs by reducing the number of patients that we bring. And if there are any questions, I'm more than willing to be here.
Alex, I have a few questions.
Yes.
Jim Langborg. The first one is, you said that you had an average on-scene time of 28 minutes with the ET3. How does that compare to your other on-scene times?
While it takes longer for the crew to be on scene, we do save considerable amount of time compared to transport and wall time at the ER. Okay. So while it is about 30 minutes on scene, it saves us an hour plus from bringing the crew back in service for emergencies or for another call.
Okay, and I'm just learning about this, so it's very interesting. And my other question is, what percentage of calls are your crews finding that they can utilize this new tool?
So since we started, we had 6 successful telehealth visits and 11 screenings. The patients that refuse to go to the ER, or sorry, they refuse to use the telehealth system, is because they either wanted to go to the ER or just refused care completely.
So that was 11 out of how many total calls? Just wondering.
There was 11 total calls that would have qualified for this, and 6 ended up being a telehealth disposition.
But out of how many like total 911 calls did it?
We do an average of like 120 911 calls a day.
Okay. Mm-hmm. All right. Thank you.
Yeah, no problem. It's still a small number, still it's at the proof of concept phase. And as we expand the payers, of course, we're going to be able to catch more and more patients. Until last Friday, it was just Medicare only. As of, we just had Central California Alliance approved. And since then, we already had 2 more calls, 2 telehealth calls. So it's gonna expand exponentially as we get more payers on board.
I'm excited.
Quick question here. So the previous slide said that 55% ended with a telehealth solution. And I imagine that means the other 45% got transported to the ER. Is like when you talk about 6 successful telehealth visits, are those patients that half of them went to the ER?
So the data that you see on the screen right here is nationwide. The 6 out of 11 is the Santa Cruz County.
So I guess my question is, of those 6, how many went to the ER after the telehealth visit?
0.
Okay, so the local data is very different than your national data then?
Yes, the local data is very different, mostly because we just started. So we're going to have outliers and all sorts of,
So I'd still like to express my concerns about how a physician doing telehealth visits in 10 minutes does all this stuff that even in an in-person visit takes me a lot longer than 10 minutes, especially without access to an EMR and a medical record and everything. So I think we want to see some more data because we have some safety concerns.
Yeah, of course. And we will try to bring somebody from Envision Healthcare for the June 8th meeting as well to answer your concerns.
Chief Klimek has a question.
Thanks. Couple questions, and I know that you don't have a lot of data, but maybe you can speak to the national data. Is how does this look when you're applying this to priority 1 calls versus priority 2 or priority 3 calls? Do you have any data for that yet?
And I don't have any data specifically to how the call was dispatched, but these are all low acuity calls. So these are all, we call them here code 2 responses. where a fire engine didn't even get dispatched to this call most of the time. So as I said, this is a very low priority that comes through the EMD system as low priority.
Okay, so I guess that was kind of where I was going with it
Yeah.
is what types of calls have you been applying these to? Have you been applying them to priority 1 calls, or do you not even go there with those types of calls?
No. This is absolutely only for low acuity, for people that can actually avoid the ED trip.
Okay.
I think it'd be a fair statement that these would not be priority 1s or priority 2 calls, likely priority 3.
Yeah,
sure. And then my follow-up to that, and I think you touched on it for a second, is that how this is looked at maybe nationally with ALS fire and your experience with that.
so here in Santa Cruz County, we have had a lot of positive feedback. I've actually joined their trainings here, and I've done this presentation to them as well. And they've seen the value of maybe even saving the transport ambulance from being dispatched to this call. Now, the only problem is that AMR has had to go through a lengthy application process with the federal government. This is a federal government grant. So it's going to take some time for ALS fire departments or even BLS fire departments to implement this program themselves. But so far, we had a lot of very positive feedback, thinking system-wide on how we can benefit the community rather than just trying to figure out like if an AMR unit is needed compared to fire and so on. So there's been a lot of feedback in terms of saving resources.
Sure. And is this program been rolled out anywhere that you know of in the country on the fire side?
Any fire department that has transport capabilities have the possibility to enroll. Before coming to California, I used to work in Houston for a different company called Acadian Ambulance, and I know a couple of fire departments that have actually implemented it there. So yes, I'm not sure. I do not know anybody in California as the fire departments have implemented this, but I know that nationwide it had quite a decent success.
Sure, but the key being a transport agency then.
It had, yeah. As of right now, it has to be a transport agency. Yeah. The ultimate goal is to reintroduce somewhat of a system of a community paramedic in place where the low acuity calls get screened to EMD and the non-emergency unit is sent to help the patient evaluate and prescribe medications. Los Angeles County, for instance, has started an advanced practitioner ET3 program where they have either a nurse practitioner or a PA respond to these calls and just use their 911 trucks for emergencies. But as I said, this is a proof of concept, and hopefully we're going to be able to improve the system to where our community can benefit more than anybody else.
Thank you.
Yeah, no problem.
Any more comments or concerns for Alex or questions?
Well, I've got a comment here. I've been trying to look at this from a potential downside. And I think the interface with the overall system, what Sam talked to, I just don't have enough right now to really formulate a good question looking at the potential downsides. I don't think we have enough data here, particularly locally, to really assess that. So I think this needs to be looked at a little bit more in depth. Michael, can you touch on that?
Hey, I mean, it is a pilot program, and admittedly, like within Santa Cruz County, obviously there's not, it's new, and we haven't had a lot of ET3, interaction, so to speak. But what I can say is that, every single, interface that we have with the patient, there's 100%, QA QI process as well. So, we're looking at both, the interfacing with the crews, with the hospitals, and also looking at, the outcomes to ensure, if there's anything that, any weak areas, all of those things. So while there's not a lot of data, I definitely think that there will be a lot of, quality assurances attached to it to ensure that, that it is a successful program. And one of the things we're going to do, I think, in the June 8th the June 8th program is invite the medical director in who can also speak to it. But again, this is seen as these very, very low acuity patients. I think if there was any question of any need, for something beyond that, we would be transporting.
Yes, absolutely. It's based on provider impression as well, along with the patient's decisions. And this speaks volume, the fact that we average about 120, 130 911 calls a day, and we had 11 eligible calls and 6 successful calls. So it's something that is starting small, mostly because it was limited by payer, but this is only, I just want to highlight this, only for low acuity patients that do not benefit from an ER visit.
If I could ask real quick, yes, you don't have that track record here in California yet. How long is the track record in New York?
It started in July of last year.
Okay, so they've got a lot more calls in a short period of time.
Correct, yes. And mostly they used to be COVID calls too. The COVID positive patients that were stable, all the vital signs looked good, and that did not benefit from going to the ER. We had one of those this morning, in fact. But yeah.
Could I just make a comment just regarding looking at downside? I think it's a really good question, Harry. And I think in addition to looking at the potential downside of the program, we should also take a look at the potential downside of not employing some sort of program to address this need within the system, in which low acuity patients come to the emergency department in high numbers and end up contributing to overcrowding in the ED, lack of resources, lack of physical space to evaluate patients, lack of ability to address the needs of high acuity patients because the EDs get so socked in with low acuity patients. And so there's a lot of, if looking at things from an emergency department perspective as an ED physician, looking at things from a system-wide perspective, there's a lot of potential downside in the way the system is currently set up. Most ED physicians and nurses will tell you that emergency departments aren't necessarily used to their most effective state, given the restraints that we have and the amount of volume that we have, particularly with low acuity patients. Not to say that patients shouldn't be there. Sometimes the ED is the only place for them to go, and the emergency department serves as a safety net for patients that can't get access to care through other means. And so I think it's a very important resource for patients, but being able to identify potentially a better way to help some patients get access to that resource without having to go to the emergency department, without having to incur the expense of an ED visit, and then freeing up EMS and emergency medicine staff to take care of the critically ill patients, I think has a lot of upside. So that's something that I think is also important to look at as we evaluate this.
Doctor, you touched on several key points there that I describe as interactive functions or interactive factors. The heavy load on the ER is one thing, and this program would obviously could contribute to reducing that. So I guess what I'd like to see is a little bit more in-depth analysis of the whole thing. You touched on many factors there, and that's kind of what sits in the back of my mind from looking at this of a emergency room which I had, or emergency facility I had under my command years ago. It could very quickly get overloaded simply because of its size and its remoteness. So I'm looking at that in both a positive and a potential negative factors. And I think that you touched on several of them there.
So from this morning's meeting at MAC, the committee felt that they also asked for more information, and we are bringing it back at the special meeting in June we could do the same for this committee. The other thing, I think that there's an advantage to this being a pilot program. It's a federal program that we can start with a small population for us to be able to monitor, implement it on a small scale, monitor it closely. And because it is a pilot program, it is one of those things that if we see that it's not having the benefit, or if it has risks, then we can pull the plug on it. But we totally understand committee members wanting to see more information. This was the first opportunity we had to bring this to you. So once AMR submitted the request to us, we looked into it. Dr. Burley actually had a conversation with the medical director of the program, and because we too had a lot of questions. So we can bring it back in June for that special meeting. Unfortunately, there is a tight timeline because in order for AMR or for Monterey County to be able to participate in this pilot program, it would have to be implemented by July 1st. So we don't have a very big window, but I think the information that is being requested exists. We can pull data from other jurisdictions where it has been implemented longer than maybe Santa Cruz. But just like Dr. Burley, I feel the same way that I would hate to miss an opportunity to bring a potentially good service to our community. So we'll do what we can to bring the information and answer everybody's questions, and with the hope that we can move this forward.
This program, if we implement it, would be a pilot program. Is that correct?
Correct.
Okay. All right.
Even at the federal level, it's a pilot program.
Teresa, and I'm sorry if I missed it. And the tight timeline is because of?
Michael, can you speak to that?
Yeah, they require that the program has to be, I think the term they use is functional with a deadline of July 1st. So we have to have some infrastructure in place and the program has to be functional. And I totally recognize, that it is a timeline and is asking a lot of the committee, but unfortunately it's nothing that we can appeal or modify.
And Mike, this is Tina. One of the questions that I asked earlier was that it's a 5-year pilot program. So since they're going to be studying it for 5 years, we wouldn't have the opportunity probably until about year 6.
That is correct.
After the data is all in, correct?
Yes, if we missed the window, then I think that we would have to wait 5 years before that we'd have another opportunity.
I have another quick question and first a comment. I think programs like this are needed and they're important, and just because they don't fit the box from the past and they may not, what we're seeing today may not be what we do in the future, it's going to be programs like this that lead to what we need to do, because obviously we do have some challenges within the total system. The one question I have is that I would imagine as you move forward with this program, if by chance, not that I'm seeing or anticipating this, but if by chance you were to see some type of negative effect as a result of it, I would imagine there's some type of a pull, a pin that you could pull to end the program, to stop it immediately, yes. Correct?
Yes, absolutely. I could just end it in 10 minutes if I want. I can just disable the visit. Like, there are measures in place to stop this at the worst case scenario, or even to tailor protocols to it. So it's a pilot program, but it's pretty flexible as well.
So basically, this is a program just to see how we can benefit the system. And if it looks like it's negative in any way, we would stop it.
Correct. This is one of the few programs actually that are patient-centered, and then everything else is developed around the care of the patient.
Excellent. Thank you.
Yeah, no problem.
Teresa had touched on this, but in MAC, we decided to table our decision regarding endorsement until we got some additional information, and we arranged. We had a special meeting already on the books for June 8th, at 9:15 a.m. At which time, we generally meet just for AB 361, but we had requested that AMR put together some additional information regarding data from other municipalities that have been using this program for longer, as well as setting up a presentation and an opportunity to discuss the program with the medical director for the physician group providing telehealth care. So that would be on June 8th in the morning at 9:15. I don't know whether it would be feasible because I know EMCC is meeting as well right around that time for AB 361. So it seems like it would be most efficient for the members of EMCC to join that meeting so that we could give everyone the opportunity to get the same information, ask all of our questions in one sitting rather than sort of divided among all the different committees. Does that sound like a reasonable approach?
If I could interject, we can certainly do so, do a combined meeting, especially if we have a majority of EMCC members, which we would need, but it would have to be it would have to be identified as an EMCC meeting to not violate the Brown Act.
Right,
So it could be both, but
being a meeting that's open to the public, anyone could attend that meeting, so that we could get all of our information, ask appropriate questions, and come away with a better understanding. And then if we needed to meet separately as EMCC, then in terms of endorsement and voting, then we could have a separate meeting to specifically address a decision on whether to endorse the program. Would that be reasonable?
you could, or you could do it as a combined meeting. It would just have to be listed as both a MAC meeting and an EMCC meeting, and there would need to be a quorum for EMCC to do anything. So that's a commitment that this group would be making, is that they would intend to be there to have a quorum.
Steve, do we need a motion for that from EMCC?
I don't believe so.
Okay.
Just plan to chair to schedule the meeting.
I would concur with that approach, with Dr. Burley's approach, and hold a meeting accordingly and vote on it.
Yeah, I'm with Dr. Burley and Harry that it would be easier if we just combine the meetings.
We will follow up with information. We'll make sure that we cross our T's and dot our I's regarding Brown Act rules in terms of having this be a joint meeting, but we'll send all the information after today.
You may have to clear that with the attorney. I hate to say that, but
that's the subtext. Yes.
Well, great. Well, thank you, everybody.
Thank you for your time. Appreciate it.
Thank you, Alex and Mike. Sam, you got a comment?
Sounds good to me. I like it.
Yeah.
I want to hear
Yeah,
more.
your box lit up just for a sec there. All right. Where are we? All right, moving on to item E, which is the EMS agency annual report. Dr. Burley and Teresa.
Thank you. The agenda had the EMS annual report for 2021. That is going to the Board of Supervisors next week. We will be giving a presentation. Just to remind the committee, we switched our reporting from fiscal year to calendar year, and we are now scheduling the item for the board, for that report to go to the board in May to coincide with EMS week. Also next week, the board will be issuing a resolution proclaiming next week EMS week. So happy to answer any questions about the report. I want to thank our partners. We cannot, I said it at the meeting before this one, that we cannot talk about even EMS agency achievements without talking about all of the work that goes from our partner agencies. So this is an EMS system report of accomplishments, and we thank you for all the work that you do.
One comment, it is comprehensive, period.
Thank you.
Dr. Burley, do you have anything to add?
Just to echo what Teresa says, in terms of all the work that we do with our partner agencies, we really appreciate the input, the collaboration. It's a system that requires a lot of different voices, and so it remains a pleasure to work with you all. And I think that we ultimately, at the end of the day, do a good job in bringing service to the citizens of Monterey County. So thank you all.
All right, thank you. Moving on now to the MAC member appointment. Deborah?
Yes, we have several members of the MAC subcommittee who have terms who are set to expire this year. Of those members, we have 3 current members and 1 alternate who have been reappointed to serve an additional term. And we would like to bring those members before this committee for endorsement today. The members impacted by this would be Benjamin Hitchcock, who's a representative of the primary ambulance contractor, Jeff Horner, who's a representative of the air ambulance providers, Carrie Cantman, who is the SVMH base hospital coordinator representative, and Jeremy Hadland, who serves as her alternate.
So move endorsement of the members mentioned.
I have a motion by Harry. Do I have a second?
Second.
That was Jim. Steve, can we get a roll call, please?
Yes, we can. Give me just one moment. All right, roll call. Will Hiller.
Will actually had to jump off the call.
Then Mike Esslinger.
Aye.
Tina Nieto.
Aye.
Sam Klemick.
Aye.
Jim Langborg.
Aye.
Harry Robbins.
Aye.
Paul Wood.
Aye.
Nicholas Greenson.
Aye.
Carlos Spencer had to step off. Joe Cafaro.
Aye.
John Anthony.
Aye.
Thank you.
All right, thank you, everybody. That motion carries. Moving now on to ops member appointment, reappointment. Kimberly?
So there are 3 members that are, I'm sorry, there are 2 members that were up for expiration in the end of June that we need endorsement or would like to have endorsement from EMCC according to the director's appointments. That's Jeff Horner for EMS aircraft provider and Olivia Madrigal for Monterey County Emergency Communications. And we have 1 new member who was nominated, Christopher Kuzner, for EMS aircraft provider alternate.
Move endorse the members so mentioned.
Harry moves. Can I get a second, please?
A second.
Paul seconded. Steve, if I could get a roll call?
Yes, roll call. Michael Esslinger.
Yeah, aye.
Tina Nieto.
Aye.
Sam Klemick.
Aye.
Jim Langborg.
Aye.
Harry Robbins.
Aye.
Paul Wood.
Aye.
Nicholas Greenson.
Aye.
Joe Cafaro.
Aye.
John Anthony.
Aye. Sorry, trouble unmuting.
Been there, done that. Thank you.
All right, that motion carries. Thank you for that. Moving on now to Amendment 11, item H. Teresa?
During contract compliance working group, we were discussing some of the changes, and it was suggested that this item be brought to the EMCC. I am going to turn it over to Kimberly, and she'll go over some of the changes.
I want to show you something. Okay, so in this PowerPoint, we kind of broke down the different sections of the amendment that were, or the sections of the amendment where the changes occurred, and the kind of broke down and fleshed out where Where the changes came from or the rationale behind them. So on the first slide here, we have section 4.1.2.4, which is behavioral health patient transport. The ambulance provider, we want to point out that the ambulance provider continues to be responsible for transporting behavioral health patients. The intent was to leave language broad to accommodate changes in long distance transports, humane treatment of patients, encourage more use of BLS, and explore other ways of transporting some behavioral health patients. And also to meet requirements of the receiving facilities. We've looked into and heard in meetings that patients should be off restraints before leaving the sending facility, and that the patient should not be aggressive when being received by the receiving facility. Any discussion on this section of the amendment? Okay, section 4.10.4.1, special events and ambulance standby. We added emphasis on subcontracting with Monterey County-based providers first before reaching out to other areas to subcontract. Establishes a timeline for submitting requests for standby ambulance services and allows a surcharge for changes made to the number of ambulances less than 14 days before an event. So if the event coordinator decided to make the change from 5 ambulances to 7, AMR is allowed to charge a surcharge. Any questions on this section?
What's the justification for the surcharge if they're increasing or decreasing? Just curious.
Go ahead, Mike.
Well, I can speak to that. Is that because it results in overtime, we typically have to mandate, in the contract, we don't have the option to reject providing a standby. So that's basically the reasoning.
Okay, thank you.
Section 4.15, interfacility transfers. It encourages the use of BLS when appropriate to help with staffing, which we talked about earlier. Transfers greater than 250 miles round trip require a 24-hour notice. That keeps the units that were already scheduled to be in the system, and this allows AMR to try and schedule an extra unit and make accommodations for those long transports. It encourages pre-scheduling. There was language added, overload language added to formalize scheduling practices that are already in existence. It allows rescheduling due to system overload, and this does not apply to Code 3 interfacility transports. Code 3 interfacility transfers cannot be diverted or rescheduled. And added use of hospital nurse for CCT transport, which was formalized in a memo in 2021.
Right.
Any questions on this section? Sections 18.2.1, priority definitions, added alpha and omega calls for which BLS response may be appropriate to priority 3. Want to note that this section of the amendment has not been implemented. This would be implemented if a tiered response were to start here in Monterey County. So it's just has language in there so that if that is something that comes about, it's already in the agreement. And added priority 7, which is an unscheduled CCT transport. Any questions? Section 18.2.6, we added the overload language, which you see in the section below. It just goes into the details of what overload is. And the reasoning behind this was it established a consistent definition and allows the EMS agency to verify that these conditions existed. So if an issue were to arise, we can verify that overload was actually happening when a transfer needed to be rescheduled. And section 18.3, ambulance response times. Changes to priority 6 critical care transport to a scheduled pickup time and added priority 7 as an unscheduled critical care transport. And then I'm going to move on to the next slide because it talks about response time more. The time interval changes the way that response time is measured. It's now dispatch time and shoot time and response time as a whole is considered I'm sorry, it's dispatch time, shoot time, and ambulance response time is the whole, which is the response time. It's an attempt to make a more patient-centric approach by looking at the total time, minimizing the penalty buckets. And the agreement already allows a 60-second dispatch time, so that was already in there. It's just moving the time the clock starts from behind the dispatch time instead of after. It allows a 60-second shoot time. AMR's internal shoot time allows 45 seconds during the day and 120 seconds at night. And the NFPA standard 1710 uses 60 seconds for a shoot time. And response time standards already prescribed in the agreement. Section 18.11.4, changes to priority assignments, specifies that changes to priority assignments will be implemented on a trial basis. And if the change has a negative impact on response time compliance, the trial period will end and the change will be reversed. Sections 18.11.5 and 18.11.6. This is in regards to CCT. It adds a $1,000 per day penalty to each calendar day when CCT RN position is not staffed by a qualified RN. AMR can submit an exemption and could be granted by providing proof of attempts to staff the CCT position. And then section 18.12.2.2, monthly penalties. The penalties were removed for priority 6. And that is priority 6 is a CCT because that was removed, and then the per day penalty was added about staffing. Section 18.14 per minute penalties, removed the per minute penalties per zone. Any questions?
I'm not seeing any questions. Thank you for the report. Moving on to the next item I, AB 361, Steve.
Yes, AB 361, of course, if we'd like to continue to meet under those guidelines rather than the more restrictive Brown Act requirements, this committee does need to find that a couple things are in place, that the governor says that there's still a state of emergency, and then of course that there's the conditions that make it preferable to meet remotely still exist. So that's what the committee is being asked to find, and then we can meet under the AB 361 rules.
We meet under AB 361.
Harry moves to continue under AB 361. Do I get a second on that, please?
I'll second, John Anthony.
And Steve, if I get a roll call, please. Thank you.
Roll call. Mike Esslinger.
Aye.
Tina Nieto.
Aye.
Sam Klemick.
Aye.
Jim Langborg.
Aye.
Harry Robbins.
Aye.
Paul Wood.
Aye.
Nicholas Greenson.
Aye.
Joe Cafaro also had to step away. John Anthony.
Aye.
Thank you.
All right, that motion passes. We'll continue under AB 361. A special meeting, do we have to take another roll call on that one, Steve, or motion on that one for the June 8th?
No, that's I don't believe so. We can.
Okay.
We have it listed as an action item. So if we've been putting that as part of the motion, if to meet on the day recommended by EMS agency staff. So that's what that is. It's mostly a tool to make sure that everybody's in agreement that they'll be here on that day.
With that, Steve, just a heads up, I will not be attending the June 8th. I will be up in the air and not on Zoom.
As an action item, I would certainly entertain a motion, I would think.
Could I get a motion?
You have a motion accordingly.
All right, Harry moves. Could I get a second?
Second,
Paul Wood seconded. Roll call, please, Steve.
All right, real quick, Mike Essinger.
Aye.
Tina Nieto,
Aye.
Sam Clemic,
Aye.
Jim Lamborg,
Aye.
Barry Robbins,
Aye.
Paul Wood,
aye.
Nicholas Greenson,
Aye.
John Anthony.
Aye.
Thank you.
Thank you. That motion passes. Moving on to announcements, good for the order. I see there's already two. Steve, the first one?
Two announcements that we have. First is the California STEMI and Stroke Summits are coming on June 27th and 28th. They'll be held virtually. The flyer is in your packet. And the second is there's an active shooter training, May 24th and 25th, and in-person training here in Monterey County. Also the flyer in your packet.
Thank you for that. Does anybody else have any announcements or anything for the good of the order?
You're muted, Tina.
You're muted, Tina.
Sorry, not seeing anything. Our next meeting is scheduled for Wednesday, July 13th at 10:30. The information will be sent out. And with that, everybody have a good day. Hey, Steve, real quick, I'm not going to be on the next meeting, but my alternate will be.
The June 8 meeting?
Or no, the one today, ops.
Oh, the ops meeting. Okay,
Got it. Thank you.
copy. Thank you.
All right. Thanks, everybody. Have a great day.
Thank you all.
Thank you.
Thank you.